Bom dia. So I would like first to thank the organizers committee for their kind invitation to be here. This is my first time in Brazil, Sao Paulo. I'm very excited, beautiful country. I apologize for not being able to speak in Portuguese. I love that language, at least the sound of it. It's so melodic, much more than Spanish for sure. But I guess that I can only say very few words. So I think there's translators, and I can keep going in English if you allow me. So I will try to, for the next minutes, to discuss with you one scenario which is linked to the very nice talk of Mauro, which regards bone and joint infections, and particularly prosthetic joint infection, when we don't have cultures. No, we have witnessed the pursuit, the search for microorganisms in the case of vertebral osteomyelitis, and we do the same for prosthetic joint infection, no? And other implants. This is the summary of my topic. I will try to discuss with you the importance of the problem, the definition of the problem, what is the magnitude, how big is this problem or not. I will go through some of the causes for culture negative implant-associated infection, and finally we'll try to discuss with you some insights on the management and prognosis of these infections. So even if we have many different implants, as you can see here, intravenous lines, or cerebrospinal fluid shunt infections, or breast implants, I will focus my talk in prosthetic joint infections. And I will do so because of several reasons. I will be honest with you, and the main reason is that prosthetic joint infections and bone and joint infections is my area of expertise, so it's where I feel comfortable, and I know well the literature and the research. But also because of prosthetic joints, apart from intravenous lines, are the implants more frequently implanted in our patients. So prosthetic joints have become the paradigm of extravascular biofilm-associated infections. We have a lot of patients. We're going to have more and more patients since our population is aging, and we are implanting more and more devices, and so the absolute number of patients with prosthetic joint infections is going to grow. And also, because prosthetic joints, as opposed to other implants, has some particularities in treatment. We know, as a rule, that whenever we have a foreign body that has become infected, what we have to do is to remove it. And by removing it, we have probably cured the patient. But in the case of prosthetic joints, this is not always the rule. In fact, many times we play the card of performing a debridement with implant retention and then giving antibiotics. So we keep the implant and we keep the biofilm. And even if we remove the implant, we know that in many cases we have to place another prosthesis in the same surgical site where the previous one was. So we need the surgical site to be sterile in order to avoid an infection relapse. So prosthetic joint infections are difficult to treat, and in this particular scenario, having culture negative infection is really a bad thing. So just in order to stress the importance of cultures, I will compare a prosthetic joint infection with a planktonic standard infection. And in this case, I just propose you to imagine a patient with an community-acquired pneumonia. We normally have a predictable etiology in these cases, and we will start empirical antibiotics. We also know that the antibiotics that we will use have a favorable pharmacokinetics. We will have good concentrations in the site of infection, and what is important, there is no biofilm, so the antibiotics are usually active. We normally have a favorable outcome, and if we don't, we know what we have to do. We know if we can widen the spectrum of antibiotics, or we can get new cultures. And normally patients are quite linear. They either go good or don't. But we know this within a few days. No? And this is very different from prosthetic joint infections. We use empirical antibiotics after surgery, but the etiology is not predictable. It can be very different from gram-positive microorganisms to gram-negative microorganisms, and so we normally use very broad antibiotic spectrums. These are biofilm-associated infections, and so the activity of antibiotics is diminished, no? And we are in a difficult position. And these are patients that are not linear. They have to undergo several surgeries. Some of them go good, some of them don't. So these patients are difficult. And what is very important, these patients have the potential of a long-term relapse. And it is very important for us as clinicians, as infectologists, to know if we were treating correctly the microorganisms, and then it is the fault of the infection per se, of the biofilm, of the surgery, or not. We weren't treating correctly the microorganisms. So I think that we all agree as infectologists that we need to know the microorganisms responsible for such a complex infection as a Prostedio infection. But then I will try to discuss with you what's the influence of not knowing this information in the prognosis and what should be the management. So when we're talking about culture-negative prosthetic joint infection, what are we talking about? I think the bottom line here is that we all are convinced that our patient has an infection, but cultures are negative. So does he have an infection, really? I think it depends a lot on the clinical presentation. If the patient has an acute infection, as you can see here, with purulent material, evident and wound discharge, there is no question. The patient has an infection, whether the cultures are positive or negative. And the problem, the clinical problem, usually stands in the patients with chronic infection who normally just present with chronic pain in the joint. And we know that we don't have a gold standard for diagnosing these patients, but a composite definition which regards clinical presentation and blood tests and radiological data and histopathology and also, of course, the microorganisms. And this has led to researchers who have to deal with these patients and who have published some case series to work with composite definitions that finally lead you to the conclusion that the patient, for sure, he has an infection, but you don't have microorganisms. No? Normally, the criteria used are the presence of a sinus tract that directly communicates the skin of the patient with the joint space, or macroscopic signs of infection such as purulent material surrounding the prosthesis. Some other authors have also used some composite definitions which regard high level of acute phase reactants or signs of inflammation in the synovial fluid, as you can see here. So how important is this problem? Is this very frequent nowadays? I don't know your experience in this regard. To have a perspective of the problem, I think that we have two sources of information. On one hand, we have case series reporting culture-negative prosthetic joint infection, which is the table that is summarizing the studies that have been published in literature. And on the other hand side, we have epidemiological studies, which are not that frequent. Regarding the first case, the table, you can see that it seems to be quite frequent, and you can go from as low as 7% to as high as 41%. I think this is tricky because most of these case series select the patients. They are patients who, they are not dealing with all the patients with prosthetic joint infection, but just very selected patients with previous antimicrobial treatment or managed with a two-step exchange procedure. So I think epidemiological studies are more reliable. I will present you two. One of them is this Australian study performed in 10 Australian hospitals with more than 150 prosthetic joint infections, and you can see here that the rate of culture-negative prosthetic joint infection was 7%. And in the low part of the slide, I don't know if it is well seen, but they have reviewed the literature, previous literature, and it's around 10%, 5%. In Spain, Natividad de Benito recently published last year a very large study comprising more than 2,500 prosthetic joint infections and assessing the etiology of these infections. And you can see that the rate of culture negative was around 10%, 9.4. And what is more important, they regarded the rate of prosthetic joint infection with culture negative over time. And you can see that the rate of infection remained in 10%, 9-10% throughout the whole period. So I think that we have evidence enough to say that culture negative prosthetic joint infection is not very frequent, but it is not rare. So it won't happen every day. Maybe in my hospital, we have like 40, 50 prosthetic joint infections per year. This means that maybe 3, 4, maybe culture negative. So I think we have to be prepared, but it is not that common. So what are the causes for culture negative prosthetic joint infection? There are some studies who have assessed this clinical question, and although they report several risk factors, the most important one, which is repeated in every single study, is the previous administration of antibiotics, which is quite common in the clinical practice. Whenever someone has a prosthetic joint and then the bone starts being red with erythema and inflammatory signs, it is quite a temptation to administer the patient antibiotics. And this will delay the diagnosis, and many times when the patient finally undergoes surgery because of his infection, cultures will be negative. So it is very important to withhold this administration of antibiotics until there is a plan of surgery and antibiotics which may allow the patient to be healed and to perform a proper microbiological diagnosis. Previous administration of antibiotics needs not to be confused with prophylactic antibiotics at the time of surgery. Some clinicians are concerned on the possibility that the prophylaxis at the time of the anesthesia induction may lead to negative cultures in the same surgery. But there are some observational and experimental studies assessing this question, and there seems to be enough evidence suggesting that there's no problem with prophylactic antibiotics. I am talking not about prophylactic antibiotics, but about treatment, previous treatment for the prosthesis. Some other causes of culture-negative prosthesis is the patchy distribution of infection, especially in the chronic scenario. As you can see here, for example, this femoral component of the prosthesis has a more evident loosening, and the frequency of culture positives here will be higher than in the tibial component. Another possibility is that the infection is caused by fastidious bacteria, which need very special media for growing and probably more days, such as mycobacteria, fungi, anaerobic microorganisms. This is true, and in many centers they have specific protocols for including this kind of cultures in the management, in the surgery of these patients. But still, look at the percentages of these infections. It is not that high. It's around 1% per type of microorganism. So this wouldn't explain all the culture-negative prosthetic infection. Another issue is how long should I keep the cultures before deciding they are negative. We know because of this very important study published 10 years ago that the majority of pyogenic bacteria grow within the first 5 to 7 days, and there are very few bacteria that grow after. Bacteria that can grow after 7 days are especially anaerobics, such as Streptococci or Propionibacterium agnes, nowadays known as Cathibacterium. So if we have the suspicion that this patient may have a Propionibacterium, for example, in a shoulder prosthetic joint infection, we should tell the microbiologist so he keeps the cultures a bit longer. It is very important also the time that lapses between the sampling of the cultures in the operating theater and the actual seeding of the sample in the media. And we have very elegant evidence showing that after 2 hours, the possibilities that the cultures become negatives are higher. So there are no reasons to delay the cultures once they have been taken in the operating theater to the laboratory. They should just go straight away. We know that if we keep these samples in the freezer, we may win some time, but the bottom line here is just to send them straight away. Finally, it's been commented in the previous talk, sonication and other molecular techniques such as PCR may increase the sensibility of the cultures, especially in the setting of previous antimicrobial treatment. So this is something to bear in mind, especially when the patient has received previous antibiotics. So all right, I've gone through the epidemiology of culture-negative prosthetic infection. We've discussed some of the causes for culture-negative prosthetic infection. We normally have surgery on these patients. We start empirical antibiotics, and then if we have the results of the microbiology, we tailor this antimicrobial therapy. But the clinical question is, what do we have to do when we don't have positive cultures and we are convinced that our patient has a prosthetic joint infection? There are some guidelines published. I have just brought the Spanish guideline, which was published last year, and the bottom line here is common sense. So how should treat a patient that I'm convinced he's got a prosthetic joint infection, but I don't have any evidence of the microorganism? Common sense means, one, just taking some clinical data. It is not the same if the prosthetic joint infection is acute or is chronic. If it is acute, I will have to cover Staphylococcus aureus, Streptococci, gram-negative bacilli, whereas if it is chronic, I will have to focus on coagulase-negative Staphylococcus, Propionibacterium agnes, and so on. It is very important also to bear in mind previous infections of the patient, because this could be a relapse. It is also very important to know if the patient has received previous antimicrobial treatments which can be held responsible for the negativity of the cultures, because if the cultures are negative because of the antibiotics, then I can say that these antibiotics are active, and so it would be a good idea to include their spectrum in the final treatment that I'm going to administer to the patient. No? And finally, it's very important to have a knowledge of the local epidemiology. How frequent is MRSA in my media? How frequent are ciprofloxacin-resistant gram-negative bacilli in my media? Because depending on that, I will give a coverage in the spectrum or not. And what do people do? People do more or less the same. This is the same table that I was bringing you before with the 8 studies published regarding this issue. And you can see that the antibiotics for culture-negative Prosterogen infection usually regard the spectrum against gram-positive cocci. No? So the use of vancomycin or other glycopeptides is quite frequent in this scenario, and the use of cefazolin or other beta-lactams also. So finally, the question resides here, what is the prognosis of my patients if I do so? So are these patients who don't have information on the microorganism which is responsible for the infection going to have a worse prognosis? The experience tells us that not, that these patients have the same prognosis as good or as bad as patients with culture-positive Prosterogen infection. And this is important because this relaxes a bit the situation. I think we have to pursue the culture for sure because we feel more comfortable and we know that we are doing things good, and this confirms many times the diagnosis. But still, if we don't have it, we don't have to panic. We have to treat with these thoughts that I was mentioning before and try to do the best. The next slide is a bit of a provocation because it could be that after surgery, the antibiotics were not that important, especially in some particular instances. We have experience with observational studies which are non-comparative and which have a low sample, suggesting that patients managed with prosthesis removal and the placement of an antibiotic spacer loaded with antibiotics such as vancomycin and gentamicin do not need long treatments. And you can see here like 14 days of vancomycin or a few days of vancomycin or 14 days with very high rates of success. So one could say, okay, if I don't need long antibiotics, maybe the choice of these antibiotics is not needed. No? If systemic antibiotics are not truly needed, getting the right antimicrobials is no longer necessary. No? Still, we are not sure of that because this is non-comparative evidence, and we have still to deal with the patients who are managed with prosthesis retention. No? And these patients, we know for a fact that they need antibiotics. And the thing is that here in the right-hand side of the slide, you can see that the prognosis of patients with implant retention is the same whether they have negative cultures or positive cultures. So I think this is a bit for a debate, but I think the results are quite interesting. So to sum up, I think we can say that culture-negative Prosterogen infection is an uncomfortable scenario for the clinician. It's happening around 10% of infections. The most important cause for culture-negative Prosterogen infection is previous antibiotic treatments, which should be avoided when possible. Treatment of patients must be based on the clinical presentation, previous antimicrobial treatments, and local epidemiology. And in spite of the difficulties, prognosis seems to be similar to culture-positive Prosterogen infection. Muito obrigado.